A while back, I dropped a reel about the narrow differential for patients presenting with hypotension and bradycardia, and a bunch of you guys sent in additional thoughts that I hadn't listed, so I figured let's get together an updated version and get it out there. The differential list is going to include hyperkalemia, beta blocker or calcium channel blocker toxicity, clonidine or dig toxicity, inferior wall MIs, advanced AV blocks, blood in the belly, neurogenic shock, severe hypothyroid states, and hypermagnesemia. Most of these pathologies we're going to be able to differentiate based on the history and physical examination. If the patient has trauma, suspect blood in the belly or neurogenic shock. If it's a young woman presenting with abdominal pain, you got to think about ruptured ectopic pregnancy. All of that blood in the belly stimulates the vagal nerve, gives you vagal tone, and that hypotension and bradycardia. If the patient's on a beta blocker or a calcium channel blocker, then suspect toxicity, and this can occur outside of overdose if the patient's got a renal hit and they're accumulating that medication. We can see the same thing with hyperkalemia. The patient gets a renal hit, accumulates that potassium, and they get that combination of vital signs. We should also consider BRASH syndrome if the patient is on an AV blocker and they have mild hyperkalemia. These two things act synergistically to cause that bradycardia and hypotension. It's a short list of causes to consider, but we've got to think about all of these if we're going to initiate the right treatment for that patient.